Dr. Paul Winston from Victoria, British Columbia, one half of the Viva Algorithm, which is Victoria, Verona, and Viva stands for to live in Italian. And this was just accepted under the following title in April of 2021. HSP is nearly ubiquitous after upper extremity stroke with a very high incidence. We know it can happen as soon as 1 week after stroke and can result in permanent loss of range of motion. The Canadian Stroke Best Practice Recommendations note there is no good guideline to treat this. The problem is likely there are multiple causes of this. We know that the sensory fibers come from the suprascapular nerve, and we know that there is a real risk of having a contraction within 6 months, up to 38% of the shoulder, 35% for the elbow, and 29% for the wrist, and stretching does not help. Spasticity is a common phenomenon after stroke that we all recognize. However, so is capsular pattern stiffness, such as early adhesive capsulitis. There can also be underlying glenohumeral pathology, and complex regional pain syndrome, well known to physiatrists, can affect up to 48% of patients in some studies. And this is CRPS presenting to clinic 2 months after stroke versus picked up very early on the inpatient unit and treated. It's very difficult to tell the different causes apart, so we can utilize diagnostic nerve blocks. For sensory fibers, we can do a suprascapular nerve block to see if we can get rid of the sensation to the shoulder to see if pain is the main inhibitor and greater range of motion is achieved. However, we may have to use diagnostic motor nerve blocks using lidocaine. In this example for the shoulder, we recommend the use of the lateral pectoral nerve block. We therefore have created the Viva algorithm. The Viva algorithm takes into consideration whether it's an isolated shoulder pain or other joints are involved. The first question is the shoulder accompanied by stiffness in the elbow, wrist, or fingers? If no, it is isolated shoulder pain and we follow that route. If yes, we go the next direction. If multiple joints are involved, we see if they meet the Budapest criteria for complex regional pain syndrome, and if so, we generally treat them with prednisone, which is commonly used in PMR, and I recommend the papers by Kalita for this subject. If no, we then do an assessment for spasticity in those joints. Most of us are comfortable with that assessment. We want to see if there's that velocity dependent of spastic muscle overactivity. If it's just in the shoulder, we will entertain whether it's adhesive capsulitis or is there some sort of heterotopic ossification or glenohumeral pathology. If we are not able to differentiate properly, then we use the diagnostic nerve blocks. We can use the sensory nerve block to suprascapular to see if it's primarily shoulder pain, and by reducing pain is the range of motion increased. Even a glenohumeral injection will be helpful. For the other joints, however, we would implement the lateral pectoral nerve block, the musculocutaneous nerve block, or the median or ulnar for the elbow and wrist. If there is increased range of motion, we can most likely believe this is due to a spastic pattern, as CRPS and capsulitis would not change. If there's greatly improved range of motion, then we can treat for spasticity with our normal treatments, including botulinum toxin. If there is no improvement in range of motion, then we assess to see if there's a hard endpoint, a palpable tendon belly, or shortened muscle belly. If they are present, then we have to rule out that it's a contracture, HO or other pathology, and if no, we are going to start all over and look to see if it is truly an adhesive capsulitis or CRPS. This is an example of a diagnostic nerve block to the lateral pectoral nerve. You can see on the left side with 4, it's very painful. On the right side after the nerve block, it easily goes overhead. I recommend that you pause the video and watch the algorithm to see if it helps. It's nice to be back in Verona.